is actually cancerous. So it is an aging problem. As men age, sooner or later they will get this condition. And up to 80% of men will get it, okay? And if they live long enough, they will get it, will be 100%. Sometimes it is symptomatic and needs treatment. Sometimes it's not that, it's asymptomatic and can be just managed by, the hand taking care. أنا حاجات ما حد يقعد ولا ده في أماكن أمان. كم مرة لازم أعيد؟ أطلعكم برا؟ هذا الصف فاضي هون. انزلوا، يلا انزلوا بسرعة. نعم. ما حد يقعد برا. المقاعد الوغنية ممنوعة. المقاعد الوغنية ممنوعة. إذا اضطريت أعيدها راح أطلع الطالب ولا تشرحون أنا في المحاضرة لازم أعيد نفسي. ما حد يقعد برا. مفهوم؟ إذا شفت حدا قاعد برا أنتوا أشهروا له إنه either get or get out. This is ridiculous. Defiance is acceptable عندي. You want a defiance? Go find university على جنة. In this university, you follow the instructions. I also follow instructions of this university. أنت أحسن مني. أنت وأنت. تقعدوش تلاقي بنات في محلات الله. Now, there are three stages. It starts by the prostate enlargement, okay? So the prostate will increase in size. Until a certain point, it's not going to cause any symptoms that is bothersome to the man, okay? To the individual. Then it will become a benign prostatic obstruction. And this is when it causes obstruction of the urethra, okay? So that micturition process, the act of urination becomes annoying, let's say at least. Okay? So these are the stages, this is how it is. Usually it starts at the age of 63 to 65 when it peaks. It continues, it could happen at any age after that, but usually 60 is the age at which the man will start seeing it. No sitting in the back. Come on, guys, أيوة محلات. Below 50 years old, usually men will not have symptoms. They might have enlargement, as we said. It starts by enlargement, but maybe they do not have the symptoms. Because first of all, there is compensatory mechanisms, and also when they are young, their urological system is also younger. Okay? Now, the normal prostate physiology. This is the prostate. It's a gland, okay, that surrounds the urethra. It's a chestnut-sized gland. يعني قد حبة الchestnut الكستنة، قد حبة الكستنة، وشكلها زي حبة الكستنة، okay? It kind of has shape on one side, and it surrounds the urethra, so that is why when it enlarges, it causes obstruction, okay? It is a soft, symmetric, and mobile on palpitation, usually rectal exam. The doctor can feel it and can move it along, left and right, okay? The size in the adult male weighs 15 to 20 grams, okay? What are the functions of the prostate? First of all, secretion of fluids that make up a portion of the 20 to 40% of the ejaculate volume. Remember, the sperm need a liquid to swim in, right? So it produces about 30% of that liquid. Also, other secretions that are mainly antibacterial that also help in survival of these sperms. So the liquid is sterile, it contains antibacterial, and it helps these sperms to swell. Now, two lots both happen during the male life. At puberty, it will, because when the male is born, it's probably 1 gram or less. At puberty, suddenly it increases in size to its normal adult weight, which is 15 to 20 grams. At age 40, another spell happens, which increases the size another 4 times. So it could reach 50 to 60 grams. Now, in the gland itself, we have 3 types of tissue: the epithelial tissues or glandular, and the stromal or the smooth muscle, and the capsule. So, from the name, epithelial glandular, that is the glandular that produces the liquid, right? The fluid. The smooth muscles, as usual, are responsible for the contraction and relaxation. And the capsule that holds them together. Okay? Both the stromal tissue and the capsule are embedded with a lot of alpha-1 adrenergic receptors. Keep this in mind as we're going to talk about the treatment. Okay? Usually, the normal prostate, it has more stromal tissue than epithelial tissue, which is a ratio of 2 to 1. Come on, pay attention to this ratio because this ratio changes with age. Okay? انتوا اللي جيتوا متأخرين. أول مرة بتيجوا على المحاضرة؟ مش مشكلة. أنا شو بحكي عن اللي قاعدة ورا؟ مش انتوا. في ضيف متأخرين. يكاد المريض يقول حضوري. ليش قعدتوا ورا؟ وأنتم عارفين إني كذا لكتشر بحكي ممنوع القعدة ورا. ليش؟ كان ما يزعجوني. Thank you. Very considerate. Inconsiderate people. ولو considerate I'll be happy. ولا لا؟ شباب بحكي مع الجيطة أنا. طبعا اللي قدامهم واللي قدامهم واللي قدامهم ما بحكي مع الجيطة أنا. لا انتوا عارفين ازعجوني، اوعوا قدام ازعجوني. Now the capsule itself is fibrous connective tissue and smooth muscles. Of course, we always have to have some kind of a container to keep it within that container. Imagine the smooth muscles and epithelial cells without anything to hold its shape. It's just going to go everywhere, right? So all these, they have to have these containers. It's also embedded with alpha adrenergic receptors, the alpha-1, as we're going to see, the subtype of alpha-1, okay? Now, epinephrine, when it's produced, adrenaline, the capsule will contract around the urethra, okay? And closing, hence remember, sympathetic nervous system stops the micturition. حكينا زمان fight and flight. If there is an animal that is urinating وشاف another one coming to hunt him, شو بسوي؟ Will stop and run. That's the action of norepinephrine, adrenaline, sympathetic nervous system. When they relax and no danger, the parasympathetic nervous system will cause relaxation and micturition act. Now, alpha-1A is the subtype that's mostly found in the prostate. Stromal tissues, smooth muscles, the capsule, all these have alpha-1A mainly. Now, in normal prostate, we higher amount the stromal tissue than epithelial tissues, as we said, 2 to 1. So stromal, which is smooth muscle, twice as much as epithelial, which are the glandular tissues, okay? When we have prostate enlargement, this ratio changes to 5:1. So now you can imagine when we have more smooth muscles, what's going to happen? More contraction. And these are the symptoms. The men who have prostate hyperplasia, usually their problem is in the going to the bathroom, not emptying completely, going back. Minutes later, they have to go again. They have to go again because of this continuous contraction around the urethra. It does not allow them to release all the content of the bladder. So they always have residual urine that makes them. So the most complaint they're gonna come to you or to the doctor is that I don't sleep at night. Why you don't sleep at night? Because I have to go to the bathroom 4 or 5 times. Some people, what they do, which is equally dangerous, they stop drinking any fluids, eating any fruits, because they think, this will cause them to go to the bathroom more often, and they cannot keep waking up to go to the bathroom. Okay? So, if you remember, when we talked about the sympathetic nervous system, the alpha-adrenergic antagonists, we said alpha-adrenergic receptors, antagonists, can actually be used for prostatic hyperplasia, benign prostatic hyperplasia. But especially they develop drugs that are more selective to alpha-1A, okay, tamsulicin, and etc. But also, as we're going to see, there are 2 players in terms of the pathophysiology. Okay, so this is the prostate surrounding the urethra, and if we have 2, if it's enlarged, and usually that the enlargement happens in the increased number of stromal or smooth muscles, and now we have more alpha-1 receptors. There is more contraction. They're gonna keep contracting around the urethra, and it will prevent the normal action of obturation, in which when a person goes to the bathroom, they can empty the bladder, not completely, but enough to allow them to go for hours without having to go to the bathroom again. In this case, it does not happen. Okay? Another layer is testosterone. Okay? After these enlargements, these growth spurs happen under the influence of testosterone. Okay? So testosterone, so first of all, we talked about norepinephrine, adrenaline, and the alpha-1A receptors. The second layer of testosterone, which is, as you know, is the basic principal testicular androgen. Androtestosterone is another testosterone hormone, but it's produced by the adrenal gland. Okay? These responsible for the benign and scrotal enlargement. They increase the muscle mass, they maintain normal male libido. Usually testosterone is converted by 5-alpha reductase into dihydrotestosterone, which you remember, dihydrotestosterone is much more potent than testosterone. It's the most potent testosterone known so far. Now, we have 2 types of 5-alpha reductase, type 1 and type 2. Type 1, you find it in the sebaceous glands, the frontal scalp, the liver, the skin. It's small amount in the prostate, okay? But it produced usually for these. And so it's responsible for baldness, for acne, okay? When it's too much. Type 2 enzyme is in the prostate and in the genital tissue and the hair follicles of the scalp also. Now, in the prostate, this dihydrotestosterone induces the growth. It is the one what is responsible for this huge growth in the prostate. So, if this is the problem, how can I solve it? 5-alpha reductase inhibitors, right? Will stop the prostate from enlargement. So, we can say that we have 2 treatments. Symptomatic to decrease the symptoms, which are the alpha receptor antagonists, the alpha-1 or the alpha-1A in particular, and want to stop the enlargement, which is the 5-reductase inhibitors. It's the most common, as I say, most men will get it if they live long enough. As they age, the prevalence of this disorder increases. Doesn't refer certain race over the other. It's found all around races in the world. Okay? So when we look at the normal prostate, you see it's normal in size. The ratio of the stromal to the epithelial is 2 to 1. Now when it's enlarged, first of all, it's bigger in size, and the ratio of the stromal or the smooth muscles to the epithelial is a huge, 5 to 1 compared to 2 to 1. Okay? Now the hormone, as we said, testosterone is converted by 5-alpha reductase into dihydrotestosterone, which is the most potent. Okay? So when we stop this operation, we keep testosterone, but it's not as potent, okay? So it's not going to cause this enlargement of the prostate. And we talked about we have two types, okay? Now, estrogen, which men have small amount, just like women have also testosterone small amount, which if we look in the peripheral tissue of metabolism of androgen, also can help increase the amount of stromal tissues. So this increase in ratio will add to the symptoms, okay? So we call these symptoms either aesthetic or dynamic. Aesthetic refers to the enlargement, okay, which is under the influence of the hormone. And this hormone is dihydrotestosterone. Dynamic refers, which is when we have the alpha adrenergic tone, which causes contraction, and it's not one uniform. So it causes contraction suddenly. The person will go to the bathroom, will be able to perform the act of micturition, but suddenly it hits and it stops. Okay? So that's why we call it dynamic. Kinesthetic, there is an enlargement that's going over time. So what are the medications that can cause, like people who take testosterone? Last time we talked about people who have low testosterone in their body, they will have low libido, right? And they will have sexual dysfunction. We give them testosterone replacement, and they will get, as a side effect, benign hyperplasia, prostatic hyperplasia. Alpha agonists, because alpha agonists will increase the constriction around the urethra. Anticholinergic drugs, as we حكينا, the parasympathetic nervous system is responsible for the act of micturition. Now I give anticholinergic, I'm going to inhibit that. And diuretics, just because they're going to cause the person to go more often, and then there will be a response to that. Okay? So what are the symptoms? The symptoms all have to do with the pathophysiology, and we can expect from the pathophysiology. For example, displeasure from residual urine. The person leaves the bathroom, but there is still residual urine that bother him. The urine stream is very weak. Okay, there is urgency. When they have to go, they have to go immediately. If frequently at night, which leads to poor sleep, and we all know how poor sleep can affect their psychological, well-being. Much force needed in order to be able to empty the verse, and of course, its effect on libido and losing libido because of this condition. So the symptoms can be either obstructive or irritative. Okay. Obstructive, okay, has to do with, the bladder outlet is obstructed, okay? We don't allow the bladder outlet, or urethra, to dilate when it's needed, then constrict when it's needed. It just constricts involuntarily. This leads to poor flow, hesitancy in initiation of micturition, post-micturition delivery, sensation of incomplete emptying, occasionally acute retention of urine. Now the other one is irritative symptoms, which have to do with the psychology. The person is irritated from the frequency, from nocturia, not being able to sleep at night, urgency and urge incontinence. All these cause irritation. This is obstructive and that is irritative. Now usually the clinical presentation usually happens at chronic prostatic inflammation because of advanced atherosclerosis of the blood supply to the pelvis, decreasing nitric oxide, decreasing production of cyclic GMP at the bladder neck and the prostate. So again, cardiovascular system is important. So if we have a problem with the cardiovascular system, it's going to contribute to the obstructive symptoms. Symptoms may vary over time. Sometimes it's improves, or it stays the same, or gets worse. Okay? So we're going to see in the treatment, we also depend on the stage. In general, we put all the symptoms together, we call them lower unit symptom loss, okay? Which are the obstructive and the irritative symptoms, and then we get to impact on the patient's quality of life, which can be caused by other disease, like what? Also, when men age, they become more susceptible to UTIs. UTIs have similar symptoms, right? When a man or woman gets UTI, they will have similar symptoms, okay? There are also the silent prostatism, okay? They have it, but they adapt to the symptoms, and they are okay, as I said. Many in our culture, so they stop drinking or eating anything like fruits and vegetables because they contain a lot of water after noon, that's it, or caffeine. So of course, if you don't have enough urine in the bladder, you're not gonna have this problem. And the man might consider waking up once a night is okay. So there is this adaptation which calls to this silent prostatism. In general, usually the man is not in acute illness, يعني مش إنه distress شديدة. If he has moderate and severe, might. And that is when they seek help, unfortunately. So the symptoms are progressive. At the beginning, they, as I said, they adapt, they ignore, they are okay with it, then it becomes more severe, and then they ask for help. Obstructive symptoms, there is a slow urinary stream, intermittency, which means they stop, there is nothing, but he can feel they have something, so they have to wait. Then another round of maturation happens, hesitancy, straining to urinate, incomplete emptying, dribbling, and the irritative symptoms, the urgency, the frequency, the nocturia. Usually, the doctor will do digital exam, the rectal digital exam, and will feel the prostate, and they can guess actually the size, and they can tell that the size have increased, and then say, okay, you have this problem, let's talk about the treatment. Blood urea nitrogen might increase serum creatinine if it has been for a long time. And they also measure PSA, which you probably covered in oncology, right? This is the same routine they also measure if they are worrying about prostate cancer, cancer of the prostate, okay? And the American Urological Association, they have a score, a symptom score, in which they can give the patient a score if they have mild, moderate, or severe. The urinary flow should be less than 10% increase in the volume. Now, when it is in progressive, it can cause to complications. For example, if you're into painful urinary retention, which could lead to acute renal failure. Hence, it's not something that the patient should be encouraged to just adapt to it. Forget about it, try to do this and to do that, okay? Persistent intermittent gross hematuria. If the shaft is in blood in the urine, they should immediately pay attention. Overflow urinary incontinence or unstable bladder. Recurrent urinary tract infections. Because if the urine coming back, it comes back contaminated, okay? And then it can cause UTI. Bladder, diverticular, bladder stones, chronic renal failure. Notwithstanding if it's continuous for a long time. Of course, you have to take medical history, medication history, maybe it's one of the medications that is causing the symptoms. Physical examination, especially digital rectal examination, laboratory tests that we talked about, and then the American Urological Association symptom score, which is here, as you cannot see. It's a very short survey, 60 questions, and depending on the answer, of course, the higher the score, the more severe is considered the symptoms. Okay? But you have it in your presentation. Now, categorize, if it's less than 7 or 7, then it's mild, it's asymptomatic, usually in big urinary flow is less than 10, but reserve urine volume is 25 to 50. If it's 8 to 19 moderate, نفس الشيء plus obstructive voiding symptom, irritable symptoms, severe after 20, all of the above بالإضافة complications of benign prostatic hypertension. طبعا treatment, as I said, depends on the stage. We want to control the symptoms, okay? We want to prevent the progression. We want to delay the need for surgical. Many people think it will help just remove the prostate, but usually this is surgery. And if the person is elderly, surgery is not very recommended when the person is advanced in age. Delay the need for surgical, also the American Surgical Association guideline management of benign, we have to follow it. Now, as we said, it starts by benign prostatic hyperplasia, lead to benign prostatic enlargement, lead to benign prostatic restriction, okay? Then the symptoms are either mild, moderate, or severe. If it's mild symptoms, watchful waiting. It could go years mild. There is no need for treatment and complication of the treatment, okay? If it's moderate, if it's with erectile dysfunction, then we should give an alpha-adrenergic antagonist and a BPH, phosphodiesterase inhibitors. If it's small prostate or low PSA, we give alpha-adrenergic antagonist. If it's large, PSA is high, then we have to give 5-alpha-reductase inhibitors in addition to alpha-adrenergic antagonists. If it's predominantly just irritative, voiding symptoms, we give alpha antagonist and anticholinergic. If we alpha-3 anticholinergic antagonist, we do the megopyramida. Okay? If it's severe and there is complication with the other symptoms, then we might have to do surgery. Surgery it could be invasive surgery, or it could be surgery بالمنظور, okay, بالمنظار, to remove excessive gland. Now, pharmacological therapy is 3 types. We have the agent that relax the prostate, and the prostate is not relaxed لما يكون ايش؟ بسبب ايش؟ what receptors موجودة هي اللي عاملة الكونستركشن؟ الألفا. فالألفا 1A particular antagonist. برضه الcholinergic system, right? Now, agents that interfere with testosterone stimulatory effect on the prostatic gland, الشيء اللي عم بيضخم البروستات. In this case مين هو؟ dihydrotestosterone. فما شو بدنا نستخدم؟ 5-alpha reductase inhibitors. And there are agents that relax the bladder itself. Like, if the bladder is relaxed, the action of picturation becomes. We all know that. The bladder have to contract. The urgency, when I feel I need to go urinate, it's stuck with the bladder, right? So I can relax it so it can hold more liquid, more volume, and it causes the person not the feeling that they have to go all the time, okay? Improve the urine storage capacity of the bladder this way. Now, to reduce the symptoms, to reduce the dynamic factors, we need to block the alpha-1 adrenergic receptors, okay? We prefer to use those that are selective for alpha-1A, okay? فمش selective, but selective على alpha-1. We have guaifenesin, alphozin, tirazosin, piptazozin, you know all these drugs. But the receptors that are selective على alpha-1A, if I don't want to give them the other one is selective because what is the side effect for inhibiting alpha-1 receptors? Hypertension. So I don't want to cause falls. And the prostate, then they fall, we still hit them out, okay? So I can give the specific one, tamsulosin, psilocybin, and also, remember in the 5 BDE inhibitors, like Viagra, are also helpful because they also cause relaxation, right? They open the blood vessels in the same way. In particular, Cialis, okay, which is tadalafil. Show me where is the tadalafil? It was the longer acting of all the other 5 PDE inhibitors, right? Now, we use the static factor. The static factor kind of related to age, the testosterone, the enlargement of the prostate. So in this case, the 5-alpha reductase inhibitors. We have 2 drugs. We have some actually. finasteride, glucosteroid, now biclotomide, another regular regime. They block the dihydrotestosterone production. So block testosterone, but however the dihydrotestosterone, which is the most potent of all of these, okay? We can also, just like with women issues, if I want to work on at the level of the prostate, I can go up, okay? Inhibiting the production of testosterone by inhibiting the pituitary, releasing luteinizing hormone. Remember, luteinizing hormone is the one responsible for production of testosterone and dihydrotestosterone in the testes. فهيبلاك by liberalized وتغيير نفس الأدوية اللي تستخدمها for women, if you remember the name. It blocks the pituitary release even by acting on the pituitary and progesterone acetate. Other drugs is drugs that can relax the bladder itself. ده حكينا. Either way we work على prostate, right, the urethra, or the bladder. Okay, so I have on anticholinergic drugs that can actually help to reduce الشعور by relaxing the muscle of the person. So حكيت أنا I want to go selective versus non-selective. So these are the second generation alpha-adrenergic antagonists. كثير مزعج المحاضرة اليوم على فكرة بدي أحكي لكم، مزعوجة منكم جدا. الحكي وعدم الانتباه. أحط لكم الغياب الحضور تاخذوها واللي مش حابب يحضر يتفضل برا. بضلش يعني كمان محاضرتين بالكثير، فليش هيك؟ شو تخلوا سمعتكم عندي مع نهاية الفصل؟ هيك حابين؟ بليز انتبهوا. These are the medications, this is the dose that should be taking, and what is the special thing about the doses. And 5-alpha reductase, as we said, because we want to inhibit the production of dihydrotestosterone, which is the most potent testosterone. One of them is selective, one of them is not selective. People who have uncontrolled arrhythmias, poorly controlled anginas, and using multiple antihypertensive or inability to tolerate hypertensive effect of alpha adrenergic agonists, so we cannot give them the alpha antagonist. So we give them the 5-alpha reductase antagonist. Of course, these drugs are within C category X, previous. I mean, they are contraindicated. You say that it's not a woman that's going to take them. But if the man is taking these medications, they could transfer them to the female partner, and hence, if she gets pregnant, they are teratogenic, okay? So the man is encouraged to, either they are using contraceptives of certain kind, or to use condoms to prevent the transfer of the fluid so that the woman does not get it. حكينا في عنا في finasteride, glucosteroid, وفي عنا where we have glucosteroid and capsule C together, so that the guy doesn't have to take 2 medications. They take one that contains 2. Combination therapy, people who have severe symptoms also have enlarged prostate gland, 40 grams, or PSA at least 1.4 and above. Disadvantages include increased medication costs to the patient, increased incidence of adverse effects, and when we have the alpha reductase and the alpha-1 antagonist, it's better for the man, but it could increase the cost and increase the adverse effects. Let's compare between the alpha adrenergic antagonist with 5-alpha reductase. I'm trying to finish the chapter today, so you don't have to have a lecture next week. فإذا بتسكتوا تسمعوا، otherwise خلاص بوقف المرة الجاية. So, الألفا-1 adrenergic antagonist, they relax the prostatic muscle. ال5-alpha reductase do they? ما بدخل, right? Decrease the prostate size, who does that? 5-alpha reductase, not الانtagonist adrenergic. Half disease progression, مين بيمنع disease progression؟ ال5-alpha reductase, ده من تاني asymptomatic treatment. Peak onset بده 1 to 6 weeks هذاك لأنه hormonal بده 3 to 6 months of course. You cannot see the effect right away. Efficacy in relieving obstructive symptoms, usually alpha 1 have that. 5-alpha reductase, it will help with the symptoms once it starts working, especially if they have very enlarged prostate. Okay? The frequency of dosing 1 to 2 times, so that once daily. The BSA will be decreased by 5-alpha reductase, but not by alpha-adrenergic antagonists. Sexual dysfunction adverse effects, of course, is going to cause ejection erectile dysfunction together. Okay? نعرف انه الانتي كولينرجيك والانتي ادرينرجيك بيعمل sexual dysfunction. نفس الشيء الفرق التست because they're going to decrease the amount of the most potent testosterone فراح يعملوا عندنا decrease libido. Cardiovascular adverse effects of course الفايف الالفا ادرينرجيك الثانيين بعدهم دخل. هلا نقارن الفوسفودايستريز مع الانتي كولينرجيك which we said we can use. Okay, الانتي كولينرجيك especially to work on the bladder line. Relaxes the prostate, BDE yes, but especially anti cholinergic. Decrease the prostate size, none of them. بقلل progression of the disease, none of them. Peak onset 4 weeks for the BDE, 1 to 2 weeks for anticholinergic. Effects in relieving obstructive الفوسفودايستريز but not the anticholinergic لأن كانوا ما بيشتغلوش إلا على البلادر. Frequency of dosing once, decrease the prostate specific antigen, none of them. هذاك بس بدنا التستوستيرون inhibitor. Sexual dysfunction adverse effect. Phosphodiesterase بالعكس we give them as they have sexual dysfunction. هذاك الانتيكولينرجيك will cause erectile dysfunction. Mild hypotension ممكن ينتج عن الفوسفودايستريز we covered it. الانتيكولينرجيك also. Both of them have cardiovascular effects and side effects. هلا البيتا 3 الانرجيك اجونست عندنا دواء واحد بيربوجان ريلاكس البروستات لا decrease البروستات سايز لا halt disease progression لا peak onset 2 weeks efficacy not frequency of dosing once per day decrease the specific antigen no sexual dysfunction no cardiovascular adverse effects yes because it is beta 3 but this also وين شغله على البلادر مش على اليوفيلا مش على البروستات. That's where the beta 3 receptor is موجودين. هلا الفوسفودايستريز inhibitors شفنا لهم مجال لانهم they cause dilation, they cause relaxation of the smooth muscles, right? So they have this effect. But especially effective إذا البيشنت عنده هاي المشكلة and erectile dysfunction or want to avoid, and especially for younger patients, okay? That is what we just said, we can use them. اللي approved, we can use anyone. The doctor have the ability to use anyone. But what is approved by the FDA for this particular indication هو مين؟ تدلفين. Okay? بنعطى 5 ملغ daily orally. Anticholinergic we said how they affect because the cholinergic system, okay, causes relaxation, بس كمان causes contraction على التريسر على المصل اللي محيطة باليوريثرا، okay, so بنعطي anticholinergic we allow العكس هيك تفتح اليوريثرا، okay. We like to use مش أي anticholinergic, we use what we call uroselective anticholinergic agents, يعني أكثر تشتغل على اليورينري tract. To inhibit الأمفرين بالذات لأنها الدايفيناسين والسوليفيناسين في الترانسديرمال للأوكسيبيوتينونز في extended release تولتيتوريدين فإذا مش just أنتي كولينرجيك. طبعا ما ننسى إنه أنتي كولينرجيك سايد إفكتس خطيرة خاصة لما يكون واحد متقدم بالعمر. But these we assume إنهم يعني more selective so should not have that problem. These are the doses. Surgery could be a conservative surgery, which is through the urethra, transurethral resection of the prostate, common and effective in improving the symptoms, or complete prostatectomy, okay, which is less frequent. And usually doctors don't like to do it, they don't have major surgery, patient is usually elderly in age, تحملش الأنستيزيا وإلى آخره. هلا physiotherapy people تروح بتعالجوا بالphysiotherapy طبعا ما فيش دائما we don't have any conclusive evidence احنا evidence based right؟ فما فيش conclusive في some herbal product types موجوده عندنا البارميتوبيري والى اخره بس قد شو موجود عندنا بالاردن ويعتقد انه مفيد بالهايبربليجيا وبالست هايبربليجيا شيء راح يوصل باول الربيع كانوا يبيعوه على الطرقات الناس بتحب ما بحبوش عنده اكله شعبيه اردنيه شماليه مش الطرقيش اخ كمين الثاني سبانخ شو هي؟ عكوب عكوب ثانك يو ليش قاعدة هيك؟ مش المفروض ان نكون قاعدين we are facing the speaker? What? I'm talking to you, yes? لا بدي على الطرف هي عارفة حالها. تعالي يا تعالي تعالي. خليني احكي لكم شيء، الشطارة شيء حلو يعني الواحد يكون شاطر، بس كمان كثير الاتيتيود أهم. This is poor attitude. I could see إنه بكرة بالتدريب رح تغلبينا ونغلبك طبعا. لأن اليد العليا. من أول محاضرة وأنت قاعدة هيك، ليش؟
أريح.
ها؟
أريح.
خليكي بعد المحاضرة نحكي معك. إذا this is يعني what outcome we expect. شو بدنا؟ بدنا improvement of the symptoms. بدنا نوقف الانلارجمنت if possible. We want to delay الحاجة للsurgery if possible. Okay. These are and how we evaluate the outcome. We look at the symptoms. هذا المريض الحسن ولا لا؟ نعمل ال UA, AUA symptoms again. Look at the objective measures of bladder empty also useful. You know what they have now? يعني بعض الأطباء الخاصين والعيادات الخاصة المتقدمة to measure كانوا they have to have يعني زي ultrasound to measure the voiding how much بيضل في البلادر. Now they allow the patient to go to the bathroom and already الباثروم بهيئ بوسيلة بقيس كل هاي الأشياء. The patient doesn't have to be uncomfortable. They just need to go empty their bladder. ترى بتدركوا إنه أنا شايفكم كلكم. لذلك اللي بتحكي معي اللي جنبها او اللي قاعده غلط انا شايفه حق الله عشان هيك بجيب هاي النظارات to see you better my dears. Okay, the adverse effects are linked to you. Okay, and this way we finish. هلا بل urinary incontinence and urinary incontinence it's not a women issue or a man issue, it's women and men issue. راح احط لكم a small presentation, okay, على e-learning and you are responsible for that one.